This is my debut in the non-neurointerventional, non-neuroradiological topics. I have been working for a committee for a few years, and I have realized that I enjoy it very much. And I have been able to use my experience on that committee to assess my own practice. So I wanted to share some of the projects I'm doing, and hopefully you will find this useful for your own practices. So I realized I was a little bit hormonal when I was writing this title, that it sounds like a cry for help, but I guess it's just that I'm always on the clinical side of everything. I'm like the working class of the department. I'm always covering, I'm on call 1 and 2. So I have to deal with all the clinical issues you have to deal too. But so I find that it's so difficult to get something done because you are so overwhelmed. And that is part of the inspiration to try to find a way to see how good you are and not to die in the attempt. So today I'm going to share with you my experience as a clinical radiologist organizing projects with other departments for quality assessment. I hope to change your mindset about what is our role in quality assessment in radiology. So far, and it's my experience that in our department is the manager who usually takes care of many of the variables we measure for their annual report. But we're not directly implicated in projects ourselves. So now we use PACS, and so it's kind of the PACS system checking and the manager, but we are not directly involved. So I want to also show how collecting data and doing these projects might become useful when you have to deal with the administration for something you need to implement. So that was the kind of secondary gaining of all this work after a few years. So since I'm a fellow, I remember that the variables we measure for our quality assessment in radiology include turnaround time. When I started, we didn't have that. But when we started using PACS, it was useful for our chief of section to start checking how long it took for us to dictate each study, and they checked this up to now, and how many studies we were dictating per day. So I imagine you can do that in your own PACS, but we never get a report or we never get any activities about that. Because obviously sometimes a study seemed like was super long, but it was because you had a phone call and then you stood up to see something and came back, so it's totally biased. So I don't think anyone is working on checking what that means. We had the peer review that is verbal. So I imagine you all relate to this when you are just working and someone comes into your office to say, do you remember that case you dictated about, and you're like, oh gosh, I missed something. So that was the peer review, the verbal feedback. Now we have digital peer review, and it's inserted in the PACS in a window of each study, each report of previous studies on the patients. So we are supposedly fitting that, but it was as I was saying earlier, I feel bad of just when I don't agree with some reports. So I mostly bias do just good peer review. So there's this human factor among colleagues that I don't know if it is really useful. So we don't have a systematic way to do it. And we go to case presentations, we go to tumor boards, to M&M rounds of neurosurgery. We have ground rounds like tonight. And we have the reports of dose exposure per exam per patient. But do you check it? No one checks that. So we hope someone is checking it because we don't have the time to do that. So we, aside from that, unless there is a major event in the department, we don't get to know about it. So we have incident reports for mostly extravasation accidents in the CT scanner. That's the most common situation. But I don't know anything else that we do in radiology department these days to improve our performance. So if we think about all the changes we have been through in the last, let's say, 10 years, you will relate to me that most of you started working with viewing boxes and plain films. You have to adapt your eyes to digital imaging, learn the software, learn all the tools. Also, you lost the secretaries who were doing the transcription. and sometimes helping us with errors that we probably did. For now, this new voice recognition system that is total danger for some words with different and difficult accents. And we not only have to do all that adaptation, but also we're doing the post-processing of many of the images we have to analyze. So for brain tumors, we do brain perfusion, and it comes in packs as a window. The source images come to packs, and then we have to use a software that was included in packs, and we can post-process the images if we want or not. But it takes 5 to 7 minutes extra per study, sometimes if there's a glitch of the software. And so we have increased a lot of things on our end, adapting to these very rapid changes. And I think, I don't know you, but I'm feeling like I'm running behind this machine of artificial intelligence, and it seems to me like it's leaving us behind. And we're not really participating in how this artificial intelligence is being designed. So thinking on all that, I realized that we need to keep a quality assessment exercise in our own practice and in the group practice in radiology, that artificial intelligence is probably the vehicle to do that. But maybe what we need is artificial intelligence to help us, not us to be supervised by the artificial intelligence softwares or new technology. We need, as the ones who have the information, to fill those databases to dictate what areas we need artificial intelligence to help us with. And how can we determine what areas we need help with if we don't know how good we are at what we're doing? So in diagnosis, how can we tell we're really reliable as radiologists? So all this together has kept me thinking, like, we have to do some sort of activities for self-assessment, group assessment, and then maybe from there we can go back to, I don't know, we don't need to invent the software, we just need help from engineers to do what we need to improve the way we do things. So that's one good reason to get involved in quality assessment, to see what areas we can work on as a group, as a community. The other major reason is that we're participants of a problem and we're pretending we are not responsible for that somehow. As radiologists, we're always sitting on the fence of many of the healthcare issues. This is an article that I found in the Times magazine from November. And this outsider is a journalist who works also with the Mayo Clinic. And I found very interesting the perspective on healthcare safety issues right now. So she describes how in 1999, there were already issues about safety in hospitals and our care was not the best. And many actions were taken at the time. Committees were created, strategies to improve all the rates of complications. And 10 years later, we haven't improved. The rates have not decreased in harm for patients admitted to hospitals or in outpatient care. So it's something that kind of kept me thinking. The source for her article comes from also a recent manual of information from the World Health Organization that I had then that I needed to check that. This is from August this year and mentions a few facts that I wanted to share with you because it's inspiring for us and why we need to rethink how we do things. So in-house admitted patients, 1 in 10 is going to be harmed by healthcare. And of those adverse events, 50% are preventable. In outpatient care, it happens, but less or in a different proportion. So we are listed, the whole healthcare adverse events is listed as one of the 10 causes for morbidity and mortality worldwide. In low-income countries, this represents 2.6 million of deaths per year. So it's not negligible what is happening right now. If you think about flying by plane, the risk of dying is 1 in 3 million. The risk of having a major adverse event while being an inpatient is 1 in 300. So it's kind of a very concerning data that we don't have available as physicians all the time. As I was saying, in outpatient care, 4 of every 10 patients has the risk of being harmed, mostly because of misdiagnosis, prescription errors, or misuse of that information for medication use. And this is responsible for 6% of the bed hospital days that we so much need, those beds. That is more or less equivalent to 7 million of admissions per year in hospital just to treat those medical errors, and it's costly. At least 1 of every $7 Canadian dollars goes into treatment of those patients. And if we think about the expenditure of a hospital, 50% of that budget goes into treatment of adverse events. The most burdensome of those events are blood clots, bed sores, and infections acquired in hospital. So based on all that, many strategies for patient safety have been implemented, and yeah, there has been great improvement. Just by washing hands, even in very poor countries, it has decreased up to 55% the rate of infections in hospitals. So it's a significant change by just doing a very simple act. So maybe, that's what we need to do. And why is that patient safety could be so efficient or so interesting? Well, because prevention is cheaper than cure. So if we do more efforts in patient safety, maybe we can save even more money. And part of that, I see it, is more from the engaging patients in their own care. We have very many concerns about patient confidentiality and not to share information, but all those strategies to share with patients their reports, their exams, we don't see it from the outsider's view. It only helps for patients to be engaged in their own care, to remind us they had a finding, that remind us they needed a treatment, that they're waiting for a phone call or a follow-up. So engaging them might not be such a bad strategy to protect them from us. The most costly of all the medical errors is related to medications. So it's abbreviations, poor writing, errors in the administration of the medication. And that counts for 1% of all the budget we have per capita for health, expenditure for health per year. So it's not negligible how the medications errors are a great part of the problem. Any failure in identifying the nature of a disease or the timely manner of doing it, so we are kind of part of that, occurs in 5% of patients in the United States right now, mostly in outpatient settings. But studies made in the States on autopsy cases has shown that the undiagnosed cause of the death was found at least 10% of patients. So we kind of participate in these statistics a little bit with our contribution to diagnosis. And it seems like medical record reviews have also shown that diagnostic errors account for 6 to 17% of all harmful events in hospital. About hospital infections, I was mentioning that just implementing hand washing stations helps to reduce those rates. And it's important because 7 of every 100 patients in rich countries, we're not talking about low-income countries, this is in rich countries, will acquire 1 or more infection while being in hospital. And for patients who are MRSA positive, the rate of mortality from that is up to 64%. So it's significant. Imagine if we implement any strategies to clean better our equipments. So we may help with that rate too. The most concerning and the largest of all the contributors to complications are procedures, interventions, and surgeries, 25%. And despite all the strategies implemented, we still account for 1 million of mortality the day of the surgery or the procedure or the day after. So it's quite significant how errors or problems during those interventions contribute to the global mortality, 7 million per year. Worldwide, there are 3.6 billion of X-rays performed every year. And so we have to consider that we are also responsible for the pertinence of those X-rays and the additional radiation that those patients get. If we remember, 10% of those are children, so we might have to do with this fact as well. The report also mentions that therapeutic radiation errors due to overexposure, radiation of the wrong patient or the wrong side of the body account for 15 of 10,000 treatments. So this is all just to give us ideas of how we can improve certain aspects of our medical care. So from this outsider point of view, I found interesting that the proposed solutions for that is that we have to think out of the box. We have to include people who are not in the medical field to give us ideas. Because right now what we have is clinical managers and healthcare administrators, and they only ring the bell when there is any harmful event. So I found very interesting that she mentions that when things are going well, no one wonders why. We know we don't really prevent any situations. We don't look for trends of dangerous events that can lead into major complications. And we have to get people from outside of the medical field to improve the strategies and techniques we're using. Because the innovations we have so far, I imagine you relate to this in your department, are checklists. We do hand sanitizing new stations everywhere, and we have posters about safety in the workplace. That I can say is the same activities we have in our department for patient safety improvement. But aside from that, we don't do anything else on a daily basis. So this report, and going back to my own practice, brings me back to the two issues I'm always kind of trying to balance. Safety and efficacy is more evident in procedural practices about safety and efficacy. You want not to have complications, but you want that your procedures are durable and that you don't have to bring back the patient. But in diagnosis or in diagnostic procedures we do every day under imaging guidance, how can we measure efficacy? So it's not so evident how we can reach that. And so we have these variables in mind about turnaround time and productivity and complications during procedures, and how can we link all those variables into projects that we can do easily, that we can achieve, and we can see the results and go back and with these results and analyze, yeah, there's this aspect we can improve. So at the beginning of all this process, I didn't know how to do it. I didn't have the knowledge or the background to connect all those dots. And what helped me was that by chance, I was sent voluntarily to participate in a committee in our hospital, which is called the Medical Evaluation Committee. It's a group of different physicians from all departments who have to achieve certain goals, like reviewing medical charts to make sure that the documentation is clear and enough. We had to look at the systematic review of the mortality of inpatients, make sure that it was expected death or not. And in the unexpected death cases, we had a second reviewer to look at what happened and what we could improve. We had the report from the Infectious Disease Committee, so we were looking at the rates, and we will look at cases of negative exeresis or negative surgeries or complicated procedures. So looking at how clinicians work for those activities, kind of I had more ideas. First, I realized they were all reporting certain data from their department, and I didn't have anything to report, like what I'm gonna to report, extravasations per month. Well, yeah, maybe. So what really pushed me forward to think seriously about it is that they asked me to replace the chair in 2013, which was a crazy idea to have a radiologist leading a medical committee. But that kind of gave me the motivation to start looking, okay, I need to present something. If the chair doesn't work harder than the members, how can I expect them to come and do something? So I needed to find a way to report any event in the department that will feed my database. Maybe not necessarily adverse incident report type of situations, but those events that we cannot report. So I was thinking Sometimes patients have very poor IV access, and we poke them several times until someone comes to the radiologist and said, we tried everywhere, we cannot find it as a chemo patient. So we said, okay, do it without Garo and keep going. So why don't we have a record of how many times we have that? Maybe we need like an IV access clinic, or is this a problem or not? So we need to start detecting things that are not officially reported because they're not a major complication, but for the patient it's a major issue not to have their exam with contrast. I needed to create projects about our performance, not only things that prevented us from doing our work. And that was kind of more challenging. And then collaborate with other departments in the committee to get their projects finished. So I was seeing, how can I help them? Like, I don't have access to their surgical data. So sources of data in radiology are audits, are incident reports, sentinel events, or digital turnaround time. We had, at the time, not access to software that could help us to look at reports, for example. So I was limited, and so the first projects I did were very flaky. So the first one I came across with was, okay, we're gonna just put a sheet on every room, and I'm gonna encourage all the technologists to report an event. And in the front desk, if they have a problem with a patient who's complaining or a patient who is not, doesn't have an appointment, and whatever problem they have, they should report it. And I'm gonna look at what are those unreported adverse events. The other project I had was one of my colleagues in the committee complained that she sent a patient for a chest x-rays from the pre-admission clinic. She never received the report. The patient it was a spine case. She did the laminectomy, and the patient came back 2 years later with a huge mass. The patient had in that x-ray a nodule that we reported, but the report never came to her, or she never read it. So how could we help to diminish the rate of unnoticed incident reports by the treating physicians? So I started giving every patient a card saying that today you had your chest x-rays, your CT scan, your MRI, don't forget to review these findings with your doctor. So engaging patients in their own care. But it all depends, all these activities, although probably had some good aspects to it, it all depended on me to be able to continue with them. I needed to go every day to see the text, and I couldn't engage enough fellows to help us with that. So any activity that we do, I realize, cannot be successful if we don't have continuity, consistency, or conformity. So we need everyone on board and a systematic way of doing them if we really want results in the long term, which is the only way to have solid projects going on. So one of the first projects we did for collaboration gave me more insight. So I was thinking, okay, how about if we look at another performance, but not necessarily radiological directly, more medical, and we will help with radiology to find the data. So where can we find the data? At the time we had PACS, and one of our residents, now staff, Dr. Chung, he designed this search engine for words in reports. So if you use that, it's a very simple software where you use certain words and you can retrieve all the reports mentioning that word in a period of time. So that has been my main help to get all the data I need in radiology. So by using that database, then I thought, okay, let's look for a clinical practice that is a basic one that has has to do with all patients in I work in a very small neurological hospital. So we have to look for patients that are under neurology and neurosurgery. And maybe let's look at a clinical practice that has significant implication in their care, like something that is really relevant if we find something. Looking at the infectious report at that year, we saw that the UTIs were the main cause of acquired infections for inpatients, and the second most common was pneumonia. So someone in the committee mentioned, that's usually aspiration pneumonias, and these patients with neurological issues, they don't swallow well, blah, blah, blah. The first thing that a patient has as a neurological patient in a neurological hospital is an NG tube. That's the first thing they do for all patients, for prevention of aspiration. So then I thought, so you think that even with the NG tubes, they get pneumonias? Because they all get the NG tube. Is that a difficult thing to do? Like, I didn't know who was doing it. And they said, well, it's done at the bedside by the nurses or the residents when they have difficulty. The resident usually supervises that. And I said, and how do we know that it's a good technique as a procedure? Well, we do an X-ray. I knew we were reading X-rays for that. So then I thought, okay, if we do an X-ray every time they do an NG tube insertion, that means that good positioning, one X-ray, bad positioning, they have to repeat it. So by looking a period of 1 year of X-rays for NG tube checkup, we were able to retrieve how many patients had the tube inserted and how many times they had to repeat it. So that gave us idea for our first project that looked like more logical and useful, NG tube insertion assessment. And it showed actually that we required 1.1 X-rays per patient every time they had a new NG tube inserted. So based on the published data we found, that was around 1.5, this proved a safe practice in our hospital. So that helped us to go back to the infections committee and just to add that information saying this is not really coming from aspiration. You have to look at other sources of infection for those patients. So it ended up being useful for them to start looking at, okay, so we need to find out other problems, and we were lucky enough that someone thought it was useful for a project for publication. So what I'm going to show you now is some other projects we have done. Some of them might look like, you know, it's just data collected, but I'm going to show them because they helped me to later on get more help from the administration thanks to having done the data collection. So I thought, okay, if I need to report every month something, and I do interventional, let's look at the angio room. How many cases we do per month, how many complications we get. Intra-procedural complications, we cannot easily track down what happens after the angio room, unfortunately. That would be ideal. But what happens in the angio room? Are we safe? Are our techs and nurses safe as interventionists or the anesthesiologists? Do we have any problems while doing treatment? So just by looking at that, I started collecting monthly data. So now we have a more rich data collection, and you may wonder, well, yeah, but what do you do with those numbers? Well, we can look at, you know, months of low productivity when one of us is away. My colleague, my former colleague left last year, Dr. Tampieri, so I was alone for 2 months, so the numbers went down. So in terms of productivity, maybe we can use this. But we use it more for complication rates and what kind of complications we were getting. So someone said, we're having problems with the closure device for femoral arteries. We always get hematomas, it's a major issue. So we looked at the complications and said, you know what, it's your impression, but it might not be real. It's not a trend, it's not a concern. So maybe it's the way you're using it, or it's the fellow, or so that helped to kind of clarify information. Sometimes we have the impression about certain events, but only looking at numbers, you can confirm that that is true or not. In stroke, as you very well know, we're closely monitored by the government, by the other departments. And having data collection that is detailed has helped me not only to see our performance, but also it ended up being very useful, as I'm going to show later on, for the administration, because of course we are totally going beyond the budget with the materials we use. And I wanted to use a system that is not the most popular because it's very expensive, but it allows me to perform better. So by analyzing the results of our thrombectomies in detail from the medical point of view, not from the manager point of view, I have also been able to see what is our preferred system to use for thrombectomies. Also, we had a colleague from anesthesia saying that we are overusing anesthesia, that they are burning down because they don't have enough people to cover every stroke, and these cases come very urgently, and most of patients are eating when they have a stroke. So for the anesthesiologist, it's a headache. They are always nervous that they have to intubate the patient because it could be a risk for aspiration, and while they intubate the patient, it takes longer. So I looked at our numbers for the last few months and I went back to them saying, listen, or 33 cases, we have done general anesthesia only in 8 patients. So maybe you are under the impression that we're using a lot of general anesthesia, but it's actually not like that. Actually, we're improving. So having this helps you to have real conversations about events or things.
How did your colleague respond to the data?
He just said, okay. His point was more about that they're not going to be able to help us in the future because, this is burning them down. I said, but, we need you all the time. Maybe we can have the RT helping to start the case and giving us more sedation. It's true that we have modified that. We're tying up the patients to the table with local anesthesia and sedation because that's the main problem, that they move, they're restless, they're confused. So implementing minor changes, we're able to get by. Because the other thing is that the anesthesiologist doesn't sleep in house. So they have to come from home for every stroke. And they didn't like that. So it's a change of practice for them. And they don't have enough people to have someone in house all the time. So again, I'm in a very small group of clinicians. So I kind of use this sometimes to go back and say, but you're saying that we're doing GA for everyone. Only 8 cases in the last few months. So it's not that bad. How about aneurysms? So these data helped me, as I'm going to show later, for showing the administration that we have done, for example, 71 aneurysms this year. Nothing unusual, but we're using more a new type of stent we didn't have before. So every time we used it, we had to call the representative and ask them to bring the stent for us. So of those 71, 15 cases already treated. So maybe this is now timing for us to change our inventory regarding that. The other thing I have been able to do is to collect my data of treatment of aneurysms since 2008 and 2016. So this is the uphill of the learning curve, and it's a very humbling exercise to see your own results, especially when you're learning how to do a treatment. And so I was able to confirm that the safety of my procedures was under what is kind of published for this type of treatments, and also I noticed that the recanalization rate, although is within what some groups have reported for rates of recanalization, is still within the same numbers, is a point of improvement. So being able to look at my safety and efficacy just by having a very meticulous data collection of everything we do. The other project I wanted to show you is more for diagnostic purposes. So I imagine some of you remember Dr. Denis Melanson. So he was my colleague and mentor, and he had this habit that in our weekly rounds, he will come with a pathology report and said, can you put up this case? So we knew what was it. So it was a case that came back as GBM, and we said was lymphoma. So he would get systematically all the pathology reports, and he will go back and look at the images. And the cases that were kind of missed or something like that, he would bring to rounds and we will review it. So I always thought that's an amazing exercise. That's how he's so good, because he looks back at his own work. It takes extra time for doing that, but that's the only way we can review our performance. So I tried to organize a more systematic way of doing it. And at the beginning, so I had the help of 2 of our fellows. And what we did was sitting down and collecting. Every time we were looking at a new tumor, we will put it aside in a blackboard. And then month by month, we will go back and say, okay, did this patient get surgery or biopsy or whatever? Yes. Okay, so let's look at the pathology report. And we will look at the images. So initially, the exercise was interesting for just demographics of what kind of tumors we get at the institute. So academically speaking, it was interesting only. But what was more important was the cases we missed. So we were able to go back to those cases and analyze the imaging and said, okay, why did I say it was an abscess? It was a met. How could I have missed that? So looking at that gave me the idea that this was a diagnostic exercise that we should try to keep. But of course, time constraints are not on our side. So because of the last 2 years of difficult time availability, I couldn't continue it. So I was able to organize it now this year again. So this year we sat down with the fellows and tried to get back to that. We haven't analyzed as many cases as we wanted, but what we realized comparing with the first exercise we did in 2017 is that the concordance, which was above 85%, but we were only 2 people dictating, has remained above 80%. And we kind of found something interesting too. Like, well, we kind of straightened up a little bit the rules of the game. We have a more clearer scoring for correlation, halfway correlation or no correlation. But what was interesting is to analyze why we have less concordance or what has changed. Now we're 7. We have different styles in reporting. We have younger people in our group. So the younger you are, you tend to say way more differential diagnosis than later on in life. So that has changed also a little bit of the quality of the group itself. So that's a friendly feedback for everyone in the group to say, listen, we have to try to be more pertinent in the impressions and try to be more to the point, reduce your differential diagnosis, or maybe we can find a kind of more unified way to report. So that I think is one of the most promising exercises, and yes, takes time. Someone has to lead it, but it's so rewarding that it's absolutely worth it. And as I was saying, when I need something, I go back to that data too. And I realized the administration started looking at my data too. So they invited me for some administrative, kind of more high-level meetings because, of course, other hospitals were looking at us doing these projects. And they were curious how I was able to put together all the information. No one in radiology in other places has done anything. So I kind of called the attention of the administrators that way, and I have totally taking advantage of that position when I needed something. So as I was saying earlier, when we started doing embolectomies, the main issue was to know what is the best system for patients. You cannot kind of change your system every time you have a different patient. So it's costly and it's not efficient. So I just started using one single system, and we went to a course and they had this different way of doing thrombectomy. They would not only grab it with the stent, they would use the stent and they would put the aspiration catheter and grab it with both. And it was one pass and great results. I was in New York. I was like, we have to use this. But I was going from 7,500 to 9,500 per procedure, just adding that aspiration system. It's not a reason not to do it, but the administration gets back to us saying, you know that we are using too much of these materials. And so I was able with my stats to show them that since I changed my system, I was saving 8 minutes, regardless how many passes I had to do. So I had more one pass good results in less time. So who can beat that? No one. The administration said, okay, keep doing what you're doing. You're doing very good. So I noticed, okay, so we need to be kind of formal with the way we ask for things, bring in numbers, bring in results, and this is a good way to do it. The other issue we had, let's say, with these aspiration pumps, this is just a simple machine, but there's a new one with more power. So we asked the administrator if we could get the newer one that, you know, it was not, they wouldn't charge for that. We just needed to have a big order. And then they said we need a cost analysis, and then it will go to purchasing for a committee. And I said, what are we talking about? So I went back right away. Half an hour later, I was with my numbers. We have done 102 cases. 88 used a pump. So if there is a more powerful pump available, please get it. We didn't have to do the cost analysis. We got the pump. So that has helped me to overcome a lot of the administrative challenges we have in interventional disease every day. So the stents I told you we're using now, the provider, so I imagine you have the same system here that we have. We have tenders, and the companies kind of get contracts with hospitals. We should all know about this because for contrast it's the same thing. So, excuse me. When you go outside of when you go outside of a contract, it becomes a problem. The representative comes to you with the material, and they bypass the regular process. So you get the material, you use it, and then it has to go all the way back to purchasing and all that, and they don't want to pay for this. And we have used 15. So I went back to the administration, to my head of division, and said, we're doing this. So of course, with this data, we were able to go back and said, we have to organize the system. We need to improvise in the way we get materials. If you find there is a new contrast and you want to use it, you have to be able to overcome those difficulties because you are helping patients doing that. You should not be involved into all that process. So I find that having this data available has become extremely useful for us to reduce the amount of headaches we have to go through to get changes in a system that is being used to have the information reported only from administrators. And when physicians complain, they complain verbally, but we don't go to them as they're used to, with numbers. We cannot speak the same language if we don't have statistics to prove them that what we're saying is meaningful. One of the projects that you might find also useful for those of you who have to deal with MRI, one of our techs came back to us saying that, since you let the fellows do all the protocols, we're having so many mistakes. So many patients are being called back for a second exam. And you're like, really? Is that true? So I did an audit and checked during, I remember it was November 2015 to November 2017, looked at all cases where we were dictating, unfortunately, this exam was incomplete because, or we apologize for the inconvenience. So with that search engine, I was able to retrieve 173 cases that were not completed or had some issues. And of those, what I found, only 11 had wrong protocols. So yeah, there were some wrong protocols, but this number didn't end up in a high callback for patients. So it was really just an impression, but the fellows were really not affecting the workflow as we thought. What was important is that many patients aborted the exam because they were claustrophobic or they were anxious during the test. So what needed to be done was to improve our oral sedation protocol for clinicians to send patients with. So that gave us an idea that we were not kind of expecting from that. And just to finalize then, I want to show you a couple of collaborations with other departments that also resulted in very interesting numbers. So one of my colleagues in neurosurgery, she was told by the intensivist that there are so many complications with EVD insertions. And the point of the intensivist was more that it's done by trainees and not necessarily supervised all the time by their staff. So that's why we're having not functioning drains. And so she said, I would like to review that, but I don't know how to reach that information. I said, I can help you. I just go to our packs and look at how many cases we have done CT scan post-EVD insertion and retrieve those numbers and gave it to her. And she was able to analyze 73 cases. Of those, we had 65% optimal position of the drain. So it showed actually better numbers than the project she did at her own hospital. She's the trauma neurosurgeon head. And so it seemed like we were safer than at the trauma hospital. But we had to analyze something that was very interesting she mentioned. The patients in a trauma center are usually younger and they have small ventricles. So it's way more difficult to put an EVD for those patients. For us, usually neurological patients have huge ventricles, so it should be a more straightforward procedure. So what it means is that our rate of failed drains should be lower, and it's not. So maybe this is a point for us to improve. And what she used this information for was to go back to her chairman to ask for a navigation system she wanted to buy. So with these numbers, she was able to kind of negotiate more with more evidence that they truly need to invest on that for safety of patients. The internal medicine colleague did another interesting project. So we had from the OR team, which is kind of a combined administration and mostly nursing team, information that we had many cancellations the day of surgery. And it seemed like it was coming from the pre-admission clinic, that they were not properly screened. So there was the impression that it all failed at the pre-admission visit. So those patients come for pre-admission, they have chest x-rays, labs. So we were kind of trying to analyze, is it because they don't have the chest x-ray the same day, that they're not well assessed for the surgery, or what's happening? So she looked back at 79 cases at a period of July 2016 to January 2017 and found 79 cases canceled. So that was not an insignificant number. And what was interesting is that most of them were for administrative reasons, not for medical reasons. They were all properly screened, but just when they were at the entrance of the OR, there was no bed for recovery, not bed in hospital. So we went back to the administration saying, your impression is probably misled by the fact that, you know, these patients get to the door and anesthesia, you know, doesn't see them the day before, but pre-admissions has seen these patients in the weeks before and they were clear for surgery. So it's really not a medical issue. So that helped a lot for that problem. And right now we're working on what is a burden for every hospital, which is the prophylaxis for venous thrombosis. So what I'm doing is looking at patients who have positive venous Dopplers who end up having a CT chest for pulmonary embolism. And we're trying to go back into those cases and see if the prophylaxis protocol was aborted or they were not following it properly. So that's a way to try to analyze why, because we have not, my impression is that we have many patients with positive deep venous thrombosis in Doppler. So this is something that we are going to try to prove or disprove. So by all this, I just wanted to give you ideas and to share my experience in trying to put together all those factors that we have available but we cannot connect together, and hopefully to inspire you to get the patient safety in your hands as radiologists, because I think we have a good factor of responsibility as the facts showed. And it's not easy to collect the data, but what is rewarding is that once you do it for a while, it's just so easy to start building up projects from that time invested. So it's a very fruitful exercise to start collecting your own data. And you might get ideas that you never thought about. What we need is to get artificial intelligence to work for us to have that data collected in an easier way and a more available way. Like not to be checked how many studies we check per day. Why that same software doesn't help us to find the reports we need or our own reports for peer review. I don't know, like we should be on board with whoever is creating these projects, with the research team, because we don't have the time to do it and we don't have the background to design this software. But if we don't get involved into projects to prove them that we need to improve these areas, there's never going to be a clear communication of what the purpose of artificial intelligence should be. And as it is, it's kind of going parallel to us, but we're not participating on anything. And I find in radiology there are so many things to explore, so many aspects of our practice that can be analyzed easily just by investing a little bit of time. And of course, because you have the experience, it's easy for you to see what areas to investigate. We just need to find a way to canalize that. I thank you very much. I hope you found this useful and interesting.